Have you ever felt that, that dull ache or maybe throbbing pain in your head and wondered, is this just a normal headache or is my body trying to tell me something more serious?
Hmm.
Headaches are incredibly common. I mean, almost everyone gets one at some point. But the whole world of head pain is surprisingly complex, isn't it?
It really is.
Today, we're taking a deep dive into your sources on headache diagnosis and treatment. Our mission,
Right.
it's to give you a shortcut to being truly well-informed,
Mm-hmm.
helping you understand the crucial distinctions, some surprising facts, and effective strategies for managing head pain.
That's right. Yeah, we're going to unpack why most headaches are, generally benign, what those crucial warning signs are that you absolutely need to look out for,
Right.
the different types of common headaches, and the latest on how they're actually managed. This information can be incredibly empowering, really.
Okay, let's kick things off then with a fact that really jumped out at me from the sources. The vast majority of patients who actually go to headache clinics, we're talking like 99%,
Yeah, it's huge.
are dealing with what's called a primary headache. That's almost everyone.
It absolutely is, and it really highlights where most of the focus needs to be. So just to clarify, primary headaches are those that aren't caused by another underlying medical disease.
Okay, not caused by something else.
Exactly. They're thought to arise from a really complex mix of genetic factors, developmental things, environmental influences.
Hmm.
Think of the big three: migraine, tension type, and cluster headaches.
Right.
And what's crucial to remember about these is that a neurological exam between headache episodes, it'll typically be completely normal.
Completely normal. Okay.
Yeah. Even during a migraine or a tension headache, you might experience, say, photophobia, that's sensitivity to light, or maybe phonophobia, sensitivity to sound.
Uh-huh.
But the rest of the neurological exam, it stays normal.
So if primary headaches are the common ones, the 99%, what makes a headache a secondary headache then?
Right. So secondary headaches, well, they are caused by or are symptoms of another underlying medical condition.
Okay.
And here's the critical difference. They usually won't get better until that specific root cause is diagnosed and actually treated.
Right. You have to fix the underlying thing.
Precisely. And we're talking about potentially more serious things here, like intracranial bleeding, maybe dangerously high pressure inside the skull, meningitis, uncontrolled high blood pressure,
Wow.
giant cell arteritis, or even, a tumor.
Okay. So definitely things you need to find.
Absolutely. And in these cases, a neurological exam usually will show abnormalities. Those findings help guide the whole diagnostic process.
I see.
Now, it's worth noting, though, that the most common secondary headaches people see in, a primary care setting are often things like viremic headaches, the kind you get with the flu or COVID-19.
Right.
Those typically resolve on their own. Or maybe acute sinusitis headaches. They usually have a normal exam, too.
That distinction is so important. And it brings up a crucial question for anyone listening. How do you know if your headache is more than just a headache? When should you really be concerned, like really worried?
This is where understanding the red flags becomes absolutely vital. There's a fantastic mental checklist, a tool called the SNOP mnemonic.
That's not OP?
Yeah, SNOP. It helps healthcare providers. And now you consider diagnoses beyond just a primary headache. It's critical.
Okay, SNOOP. Let's break down what each letter of that alarm system stands for. What's S?
Let's do it. S is for systemic symptoms or secondary headache risk factors.
Systemic symptoms.
Yeah. Think about things like unexplained fever, maybe unintended weight loss, or known risk factors like HIV, a history of cancer, pregnancy, being on blood thinners, or severely high blood pressure. We're talking like over 180, over 120. These are signs your body might be dealing with something bigger.
Got it. So S is about those broader body signals, the bigger picture. What about N?
N stands for neurologic signs or symptoms. These are new neurological findings that pop up with the headache.
New neurological, like white.
We're talking about confusion, impaired alertness, maybe a really stiff neck medically that's neutral rigidity, swelling of the optic nerve, which is called papilledema, issues with your cranial nerves, or maybe problems with motor function like weakness or coordination issues. Any of these appearing with a headache is a serious red flag.
Okay, that makes perfect sense. Definitely concerning. And then we have two O's. What's the first one?
The first O is for onset. how the headache starts. We're looking for headaches that strike really suddenly, abruptly, or feel like a split-second event.
Split second.
Yeah, it's often described as a thunderclap headache, meaning it goes from basically zero to excruciating pain almost instantly.
Wow, just like that.
Exactly. Also concerning are headaches that begin with exertion, like exercise or sexual activity, coughing, or sneezing.
Oh.
These can sometimes point to increased pressure inside the skull.
So it's not just the intensity maybe, but the speed of the onset that's a real alarm bell.
Precisely. That suddenness is key.
And the second O.
The second O is for onset, age at onset. So when in life the headaches start. If a new type of headache begins at an older age, specifically over 50 years.
Over 50. Okay.
Or at a very young age, say under 5 years, it's considered a red flag. A brand new headache pattern in someone over 50 especially needs careful investigation.
Right, you want to know why it's starting now?
Exactly.
And finally, P for prior headache history and other Ps. What falls into that category? Sounds like a catch-all.
It kind of is, but it covers a few really important things. First, a significant change in the quality or the frequency of a headache from your usual pattern, if it feels totally different or is happening way more often.
Okay, a change from the usual.
Yeah. Second, positional changes, meaning a headache that gets dramatically better or worse when you stand up versus lie down, or maybe changes with specific neck positions.
Interesting.
And then, as we touched on under neurological signs, papilledema, that's visual problems because of optic nerve swelling, also falls under this P as a serious sign.
Got it.
So SNOP isn't just, a cute acronym. It's a crucial mental filter for sorting out those generally benign headaches from the potentially dangerous ones.
That's a really powerful tool to have in mind. So, okay, if most headaches are primary, what are these different types? How do we tell them apart? This is where it gets really interesting, right? Diving into the specifics.
It does, yeah. Let's start with the most common one, the tension type headache.
Okay, tension type.
These typically last anywhere from, say, 30 minutes up to a whole week, though for most people it's usually more like 1 to 24 hours.
Right.
The pain itself is usually described as a pressing, kind of non-throbbing sensation. It's mild to moderate in intensity and often felt on both sides of the head like a band.
Like a pressure bench, yeah.
Exactly. And crucially, with a tension-type headache, you'll usually have little to no nausea and only one or maybe none of either light sensitivity or sound sensitivity. If you have more than one of those, it often starts pointing towards migraine.
Okay, so fewer associated symptoms.
Right. And these headaches are common in both men and women, though women seem to get them slightly more often, maybe a 5.4 ratio.
So it's that general all-around head pressure feeling.
Yeah.
I remember a good example from our sources, like a 40-year-old woman saying, during a headache, I just have this constant pressure and pain on both sides of my head. I've had headaches like this since I was maybe 11, especially when I'm really stressed. That sounds pretty classic, Chris.
Absolutely. That's a textbook tension type presentation. The stress trigger is very common too.
Okay. So what about migraines then? Let's start with migraine without aura.
Right. Migraine without aura. These headaches usually last longer, typically between 4 and 72 hours.
Wow, up to 3 days.
Yeah, they can be quite disabling. The pain is usually on one side of the head unilateral, although sometimes it can be on both. It's often described as pulsating or throbbing, that pounding feeling, and it's moderate to severe in intensity. It also tends to get worse with just normal physical activity like walking, or it makes you want to just lie down in a dark room and avoid activity altogether.
Yeah, I've heard that. Just wanting to hide away.
Exactly. And during the migraine itself, people commonly experience one or more of nausea, sometimes vomiting, and definitely that sensitivity to light photophobia and Lamour's sound phonophobia.
So multiple associated symptoms are key here.
Definitely. And migraines are significantly more common in women, about 3 times as often as in men. Plus, there's usually a strong family connection. Something like 70 to 90% of sufferers have a family history.
That's a huge genetic link.
Yeah.
So much more intense specific symptoms than a tension headache. The sources had a great example for this too. A 28-year-old woman says, during a headache, I get this throbbing feeling on one side of my head. It's worse above my eye and kind of at the base of my skull. I feel sick to my stomach when I have one. For the past 12 years, most of my headaches happen the week before my period. My mom and my sister get headaches just like this. I mean, that paints a really clear picture of migraine without aura, doesn't it?
Precisely. The location, the quality of pain, the nausea, the timing with her cycle, and that family history, it all points strongly to migraine without aura.
So that's migraine without aura. What about migraine with aura? What exactly is an aura? Sounds a bit mystical.
Yeah, it does sound a bit strange, but it's actually a specific neurological event. Migraine with aura is basically a migraine headache that's accompanied by or sometimes preceded by this aura.
All right.
An aura isn't the headache itself, but it's a temporary neurological disturbance. It often involves vision. People might see flashing lights, zigzag lines, maybe shimmering spots, or even have temporary blind spots.
Visual disturbances. Okay.
Yeah, but it can also manifest in other ways, like tingling or numbness, usually starting in the fingers and moving up the arm, maybe affecting the face or tongue,
Yeah.
sometimes speech difficulties, or even just a strange feeling like dread or anxiety, unusual fatigue.
Huh. So it's not just visual.
Not always. These aura symptoms typically develop gradually over several minutes, maybe 5 to 20 minutes, and crucially, they usually shouldn't last more than an hour.
Only an hour. Okay.
Right. If an aura symptom lasts longer than that, it definitely warrants looking for other possible causes. And just like migraine without aura, there's a strong family history component here too.
Fascinating. Okay, that clarifies aura. And finally, the intensely named cluster headache. That one sounds pretty serious just from the name.
It is. It's considered one of the most painful conditions known to medicine. Its intensity has unfortunately earned it the nickname suicide headache in some circles because the pain can be so unbearable.
Wow. Okay.
The key feature of cluster headaches is their pattern. They tend to occur in groups or clusters. So someone might get headaches daily, sometimes multiple times a day, for several weeks or even months.
Daily for weeks.
Yeah. And then just as suddenly, they might disappear completely for months or even years before another cluster starts.
That pattern is really unique.
It is. And they often strike at characteristic times of the year for some people, like around the spring or fall equinoxes. And during a cluster period, the attacks can happen 1 to 8 times a day, often at the very same time each day.
Like clockwork.
Exactly. In fact, a very common time is about an hour or so after falling asleep. The intense pain literally wakes the person up, which gives it another nickname, the alarm clock headache.
Waking you up from sleep with that level of pain? That sounds absolutely brutal.
It really is. The pain itself is almost always severe, excruciating even. It's usually located behind one eye or around the eye and temple area. People describe it as a steady, deep, boring, or burning pain, sometimes like a hot poker in the eye.
Oof. Horrible description.
It is. The pain builds rapidly, reaching peak intensity very quickly, and usually lasts anywhere from 15 minutes to maybe 3 hours, but most commonly around 30 to 45 minutes per attack.
Shorter duration than migraine, but maybe more intense.
Often, yes. And what's really distinctive about cluster headaches is that they're almost always accompanied by specific symptoms on the same side of the face as the pain.
Same side only. Like,
Things like a red, watery eye, maybe a drooping eyelid, constriction of the pupil, or a stuffy or runny nostril, sometimes facial sweating. These are called ipsilateral, meaning same-sided autonomic signs. Seeing those really points towards a cluster headache diagnosis.
okay, those same-sided symptoms are a key clue.
Definitely. And unlike migraines, cluster headaches are far more common in men than women. The ratio is somewhere between 3.1 to maybe even 8.1 men to women.
That's a big difference from migraine.
Huge difference. And family history is present, but less common than with migraine, maybe in about 20% of cases.
Let's look at an example for this one, too. We had a 32-year-old man in the sources who said, during a headache, I have really strong, constant pain behind one eye, along with a runny nose and watery eyes on that side. I had my first one like this just a few years ago. My grandfather had headaches just like this. I mean, that seems to check all the boxes for cluster, doesn't it?
It certainly does. The severe one-sided pain behind the eye, the autonomic symptoms, runny nose, watery eye on the same side, the relatively recent onset in adulthood, and even the family history, though less common, it all fits perfectly with cluster headache.
Okay, so we've distinguished the main types: tension, migraine with and without aura, and cluster. But what can actually help when one of these strikes? Or maybe even better, how can you prevent them from happening in the first place? And, for people worried about something serious, should you always get a scan for a headache?
Right. These are the really critical, practical questions, aren't they? Let's start with the foundation of management, which is often surprisingly effective, but honestly sometimes underutilized: lifestyle modification.
Changes, okay.
Yeah. This basically means recognizing and, as much as possible, avoiding your individual headache triggers.
And what are some of those common triggers? I feel like I've heard food can be a big one for some people.
You're absolutely right. Diet plays a role for many, particularly with migraines. Now, sometimes small amounts eaten infrequently might be okay, but common dietary culprits that people are often advised to avoid include things like rape cheeses, think cheddar, Stilton, brie.
The good stuff.
Huh.
Mhm.
Yeah, unfortunately. Also, processed meats like sausage, salami, pepperoni, hot dogs. Pizza can be a trigger for some. Things like chicken liver, pate, pickled or dried herring, anything pickled, fermented, or marinated.
Okay, lots of preserved foods.
Exactly. MSG is a big one, found in soy sauce, meat tenderizers, seasoned salt, even some seemingly healthy things like freshly baked yeast products, sourdough bread, chocolate, nuts or nut butters, certain beans like faba beans or lima beans, onions, figs, raisins, papayas, avocados, red plums, citrus fruits, bananas.
No.
It's a long list.
Wow, that covers a lot of ground.
It does. And then there are beverages. Caffeinated drinks like tea, coffee, cola, energy drinks, or actually caffeine withdrawal can be a trigger. Alcoholic beverages, especially red wine, but also beer and whiskey, and artificial sweeteners like aspartame.
So for us coffee lovers, even missing our usual cup could trigger a headache.
Yeah.
That's a tough one. What about triggers beyond food?
Oh, yeah, plenty of those too. There's a whole host of other potential lifestyle triggers. Hormonal changes are huge for many women related to menses, ovulation, or pregnancy.
Right, we saw that in the migraine example.
Exactly. Illness of any kind can be a trigger. Physical factors are important too. Intense or unusually strenuous activity, especially if you're normally sedentary. Changes in sleep patterns, getting too much sleep, too little sleep, or dealing with jet lag.
Sleep is key.
Absolutely. Also, altered eating patterns like fasting or just skipping meals. Environmental triggers are common. Bright or flickering lights, excessive or repetitive noises, strong odors or fragrances, tobacco smoke, even things like weather changes, shifts in season, or high altitude.
Weather changes.
Yeah.
Interesting.
Yeah. Changes in barometric pressure can be a trigger for some. And finally, certain medications themselves can trigger headaches. Some antidepressants like SSRIs or SNRIs, ironically, even overusing pain relievers, which we'll talk about, and hormonal contraception. And of course, stress, or sometimes even the letdown after a stressful
The
period.
letdown effect, yeah. So basically, routine is good.
That's the core message. People with primary headaches generally experience fewer problems when they maintain a really regular schedule. Adequate sleep, good nutrition, staying hydrated, and getting consistent, moderate exercise. It sounds simple, but it can make a huge difference.
That makes perfect sense. Okay, so beyond lifestyle, what about medications? What's the difference between treating a headache that's already happening versus trying to prevent one?
Right, so we generally think about two main medication approaches: abortive or acute therapy and prophylactic or preventive therapy.
Abortive and prophylactic, got it.
Exactly. Abortive therapy is what you take when a headache has already started to stop it in its tracks, or at least relieve the symptoms.
Right, to abort the mission.
Pretty much. And these work best when taken early, right at the onset if possible. Common options include general pain relievers like NSAIDs, ibuprofen, naproxen, and acetaminophen.
Okay, the over-the-counter stuff.
Often, yes. But here's a really crucial point. You should try to limit using these simple analgesics to no more than 2 treatment days per week.
Only 2 days. Why is that?
Because, kind of ironically, taking them too often can actually cause more headaches. It's a condition called analgesic rebound headache or medication overuse headache. It can trap people in a really difficult cycle of pain.
Wow, okay. That's a really good heads up. So the thing you take to help could actually make it worse if you overdo it.
Precisely. It's a common problem. Now, for migraine-specific acute medications, we have several classes. Triptans are probably the best-known things like sumatriptan or rizatriptan. There are also select ergot derivatives like dihydroergotamine, and newer classes called diantans like lasmiditan and gypens like ubrospan.
Lots of tans and pans.
Yeah, the naming conventions can be tricky, but these migraine-specific meds are often highly effective, and again, they work best when taken right at the headache onset.
Okay.
Now, there's an important caution here. Triptans, ergots, and ditans need careful consideration or should be avoided altogether if you're pregnant, have known cardiovascular disease like a history of heart attack or stroke, or have poorly controlled high blood pressure. This is because they can potentially constrict blood vessels.
Okay, so safety concerns for some people.
Yes, definitely need to discuss those risks with a doctor. Interestingly, triptans are also sometimes used for severe tension headaches that don't respond to standard pain relievers, and they're a key acute treatment for cluster headaches too. often given as an injection or nasal spray, sometimes along with high-flow oxygen.
Oxygen for cluster headaches.
Yes, inhaling 100% oxygen through a non-rebreather mask is a very effective and safe acute treatment for many people with cluster headaches.
Fascinating. Okay, so that's abortive therapy. What about the other side? Prophylactic or preventive therapy?
Right. Prophylactic therapy is about taking medication regularly, usually daily, to minimize the risk of developing a headache in the first place. The goal is to reduce frequency, severity, and duration.
Trying to stop them before they start.
Exactly. Now, most of these preventive medications take some time to work. You often need to take them consistently for several weeks, maybe 4 to 6 weeks, before you really notice a clinical effect. So patience is key.
4 to 6 weeks.
Okay.
Not an instant fix.
Definitely not. For migraine prevention, some of the medications with the best evidence include certain beta blockers like metoprolol or propranolol, some tricyclic antidepressants or TCAs like amitriptyline or nortriptyline, and certain anti-epileptic drugs or AEDs like divalproex sodium or topiramate.
So drugs originally for other conditions can prevent migraines.
Yes, exactly. It's about how they affect brain chemistry or nerve signaling. There are also nutritional supplements with some evidence for migraine prevention, like butterbur, feverfew, coenzyme Q10, magnesium, and riboflavin, which is vitamin B2.
Supplements too. Interesting.
Yeah, often worth considering. Now, for cluster headache, the main prophylactic medication is actually lithium, which is more commonly known for treating bipolar disorder.
Lithium for cluster. Okay.
And then there's a newer class of drugs we mentioned for acute treatment, the CGRP antagonists. Some of these are also available as preventive treatments, often given as monthly or quarterly injections, like erinumab or fremanezumab. One oral gepant, ubrogepant, is also approved for prevention.
The CGRP drugs, I've heard about those.
Yeah, they're quite targeted. They tend to be among the quickest onset for prevention meds, maybe showing effects sooner than 4 or 6 weeks, and they're generally well tolerated. They're typically used if those first-line prevention medications like beta blockers or TCAs haven't worked or haven't been tolerated, partly because the CGRP drugs are often more expensive.
Makes sense.
Yeah.
So when does someone actually need a preventive medication? It sounds like a commitment.
That's a really good question. Prophylaxis is generally indicated for people who have frequent migraines. The usual threshold is about 3 or more migraine headache days per month, or maybe fewer if the attacks are particularly severe or disabling.
3 or more days a month?
No, okay. Right. Or if their attacks significantly interfere with their daily routines, like missing work or school, even when they use acute treatments. It's also considered if acute treatments just aren't working well enough, if there are reasons someone can't take acute treatments, contraindications, or if they're overusing acute treatments, running into that rebound headache problem we talked about.
To break that cycle.
Exactly. The main goals of prophylaxis are simple. Reduce how often headaches happen, make them less severe when they do occur, and hopefully allow those acute or abortive medications to work better when needed.
Got it. Reduce frequency and severity.
Precisely. And just quickly, there's also something called rescue therapy. This is for times when the standard acute treatments just aren't cutting it, or for particularly severe symptoms like persistent nausea. Examples might include specific anti-nausea medications or maybe a short course of corticosteroids. Opioids, though, like codeine or oxycodone, should generally be avoided for headache management due to risks of dependence and medication overuse headache.
Avoid opioids.
Yeah.
Yeah.
Ultimately, what's really fascinating here and important to remember is that the best medication, whether it's for acute treatment or prevention, is really the one that works best for that particular patient, considering effectiveness, side effects, and their individual health profile.
It's a very personalized journey, isn't it?
Absolutely. Trial and error is often involved.
That personal touch is so key. So let's try to bring all this information together with this specific patient from our sources. Let's call her Katie. She's described as a 33-year-old woman with a 10-year history of these one-sided pulsating headaches. They happen 3 to 4 times per month, lasting anywhere from 6 to 24 hours. And typically, they're preceded by a gradual onset of paresthesia, that tingling or numbness we talked about, affecting her face and arm. She reports severe sensitivity to light and sound and notes her cousin, mother, and sister have similar headaches. Importantly, she misses work at least once a month because of them.
What's your take on Katie's situation based on everything we've discussed?
Okay, based on Katie's really detailed description, her diagnosis seems quite clearly to be migraine with aura.
With aura, okay.
Yes. The paresthesia she describes affecting her face and arm, that is the aura symptom. And all the other characteristics, the unilateral pulsating pain, the moderate to severe intensity causing her to miss work, the photophobia and phonophobia, and that really strong family history, they all fit perfectly with the diagnostic criteria for migraine.
Right, it lines up very well.
It does. And given how frequent her headaches are, 3 to 4 times a month, and the fact that they're significantly impacting her life, causing her to miss work, and assuming over-the-counter meds aren't fully effective, which is implied.
Yeah, sounds like it. Then both an appropriate acute treatment, like an oral triptan perhaps, and initiating migraine preventive therapy would be very reasonable choices for her. She meets the criteria for prevention.
Okay, so both attack treatment and prevention make sense. Now, Katie also asked her doctor if she needs any tests, like scans, to see what's causing her headaches. What would be the right advice for her?
That's a common and understandable question. For Katie, the best initial step would likely be to keep a detailed headache diary for the next month or two.
A diary, not a scan.
Right. Here's why. Primary headaches, like Katie's migraine with aura, are diagnosed clinically. That means the diagnosis is based on her detailed history, the pattern, the symptoms, the family history, and a thorough physical and neurological examination.
Okay.
If her neurological exam is completely normal between attacks, which is typical for primary headaches, the neuroimaging like an MRI or CT scan is usually not necessary or indicated.
So scans are usually for ruling out the secondary causes.
Exactly. Scans are typically reserved for situations where we suspect a secondary headache, maybe because of red flags from the SNOOP mnemonic, or if the neurological exam is abnormal. For a classic primary headache presentation like Katie's with a normal exam, imaging usually doesn't add much value and can lead to unnecessary costs and anxiety.
That's a really helpful clarification for people. Saves worry and money, perhaps.
It often does. The headache diary, though, is really valuable. It helps confirm the diagnosis, track frequency and severity, identify triggers, and assess how well treatments are working.
Good point. Now, what about her other question regarding family planning? Given her history of migraine with aura, what advice would be appropriate regarding contraception?
That's another important consideration. Given Katie's history of migraine with aura, a combined hormonal contraceptive, meaning one containing both estrogen and progestin, like many birth control pills, is actually considered the least desirable contraceptive option for her.
Least desirable. Why is that?
Well, firstly, as we noted from the sources, hormonal contraception itself can sometimes be a trigger or worsen primary headaches for some individuals. But more importantly, having migraine with aura is associated with a small but statistically significant increased risk of ischemic stroke. Adding estrogen, particularly in combined hormonal contraceptives, can also slightly increase stroke risk. So combining those two risk factors is generally avoided if possible.
Ah, so it's about the combined risk profile.
Exactly. Progestin-only methods, or non-hormonal methods like copper IUDs, are generally considered safer options for women with migraine with aura who need contraception. It's a crucial discussion to have.
Excellent insights, really practical. Okay, to maybe solidify some of these treatment ideas, let's play a quick matching game. We've got 3 patient scenarios from the source material, and we need to match them with the most appropriate medication choice based on what we've learned. Ready?
Let's do it. Mini quiz time.
Okay, scenario 1. A 33-year-old, otherwise well woman. She has 8 migraine days per month, so quite frequent, and she has already failed to improve with, or maybe couldn't tolerate, multiple standard controller or prophylactic medications. The list includes a TCA, a beta blocker, anti-epileptic drugs, riboflavin, and magnesium. So she's tried a lot of the first-line stuff. What's the most appropriate next step for prevention?
Okay, so this patient has frequent migraines and has already been through several standard evidence-based preventive options without success. In this situation, moving to one of the newer agents makes sense. The most appropriate medication choice here would likely be an injectable CGRP inhibitor like erinumab, fremanezumab, or galcanezumab.
And why is that the best choice here?
Because our sources state that these CGRP antagonists are typically used precisely when there's been no or only a limited clinical response to those first-line prevention medications she's already tried. They have a different mechanism of action, are generally well tolerated, and might offer her relief where other options have failed.
Makes perfect sense. Okay, scenario 2. A 28-year-old woman, she has 6 tension-type headache days per month. She also struggles with initiating and maintaining sleep. She mentions having a significant insurance copay, so cost is a factor, and she's looking for controller or prophylactic therapy for her tension headaches. What fits best here?
All right, so we have tension-type headaches, sleep problems, and cost concerns. Considering all that, an oral TCA, tricyclic antidepressant, like nortriptyline or amitriptyline, would be a very appropriate choice.
Why a TCA?
For a few reasons. First, TCAs are established prophylactic medications with good evidence for preventing tension-type headaches. Second, a well-known effect, sometimes considered a side effect but useful here, is that they can help with sleep initiation and maintenance, directly addressing her sleep issues. And third, TCAs are generally older medications, available as generics, making them much more cost-effective than many newer therapies, which helps with her copay concern. It ticks multiple boxes for her.
Great reasoning. Covers all the bases. Okay, final scenario. A 55-year-old woman. She has a history of acute coronary syndrome, so significant heart disease. She has tried acetaminophen for her acute migraine attacks, but it only gives her limited relief. What would be a safer and potentially more effective acute medication for her migraines?
This one requires careful consideration because of her cardiac history. The most appropriate medication choice here would likely be an oral gepant, such as ubrogepant or megepant.
A gepant. Why not a triptan, which is often a go-to for migraines?
Because our sources explicitly advise caution or complete avoidance of triptans, ergots, and dienins in patients with established cardiovascular disease, like her history of acute coronary syndrome. That's due to their potential to constrict blood vessels, which could be risky for her.
Right, the vasoconstriction risk.
Exactly. Gepants, however, work through a different mechanism involving CGRP. They are not known to cause vasoconstriction and are not listed with the same cardiovascular cautions in the source material. In fact, CGRP antagonists in general are described as generally well tolerated. So, while acetaminophen wasn't enough, a gepant offers a potentially more effective and safer migraine-specific acute treatment option for her, given her cardiac history.
Excellent. That really highlights how important the patient's whole health picture is in choosing the right medication.
Absolutely critical.
Okay, earlier we spent some time talking about those crucial red flags for secondary headaches, using the SNOOP mnemonic. Let's look now at a powerful, real-world example of exactly when a headache signals something far more serious. This brings us to Mrs. Jensen's case from the sources.
Right. Mrs. Jensen's case is a classic and really important example. She's an 82-year-old woman who presents with a 3-day history of a new right-sided headache. It's accompanied by right-sided jaw pain, specifically when she chews. This is called jaw claudication.
Pain with chewing. Okay.
Yeah. She reports she's eating very little because of this pain, but she is managing to drink liquids. And she told her doctor quite vividly, "I can hardly wash my hair. My scalp is so sore. I have never had a headache like this in my entire life." That "never had a headache like this" is a key phrase.
That sounds like a big red flag right there.
Huge red flag, especially the new onset in someone over 50 and the quality being different. Her blood pressure is also elevated at 168/88. And on physical exam, the doctor finds a tender, palpable, meaning they can feel it, but pulseless structure in her right temple area. That's likely the temporal artery. She does mention a remote history of migraine without aura, but states her headaches have been very rare since she was about 51.
So new severe headache, jaw pain on chewing, scalp tenderness, older age. What does this picture suggest?
Mrs. Jensen's presentation is highly suggestive, almost textbook, for giant cell arteritis, GCA, which is also known as temporal arteritis.
Giant cell arteritis, okay?
Yes. This is a type of vasculitis and inflammation of blood vessels. Specifically, it's an autoimmune condition where the body mistakenly attacks its own medium and large-sized arteries, very commonly including the temporal arteries on the sides of the head.
An autoimmune attack on the arteries.
Exactly. It typically affects individuals over the age of 50, most commonly between 50 and 85, and it's more common in women than men. It's also often seen occurring alongside another inflammatory condition called polymyalgia rheumatica, which causes muscle pain and stiffness. The inflammation and swelling of these arteries narrows them, reducing blood flow, and that leads directly to her symptoms like the headache, the scalp tenderness, and the jaw pain on chewing.
Makes sense. So given that strong suspicion, what's the first test her doctor would likely order to help confirm this?
The best initial test to support a presumptive diagnosis of GCA is an erythrocyte sedimentation rate, ESR, often ordered along with the C-reactive protein, or CRP level.
ESR and CRP,
Right.
inflammatory markers, right?
Exactly. Our sources emphasize that a significantly elevated ESR, sometimes strikingly high, like over 100 millimeters per hour, along with an elevated CRP, are the typical initial lab findings that strongly suggest GCA. Now, the definitive diagnosis ultimately requires a biopsy, actually taking a small piece of the superficial temporal artery and looking at it under a microscope.
A biopsy of the artery.
Yes. But because GCA can cause serious complications quickly, treatment is often started based on high clinical suspicion and those elevated inflammatory markers even before the biopsy results are back. The ESR and CRP are usually the crucial first step to guide that rapid treatment decision.
Okay, so start treatment fast based on suspicion and labs. What would that treatment plan likely involve, knowing how serious GCA can be?
The cornerstone of treatment for GCA is immediate and long-term high-dose systemic corticosteroid therapy. Usually this means prednisone, started at a relatively high dose, often around 1 milligram per kilogram of body weight per day.
High-dose steroids. Okay. For how long?
This high dose is typically continued until the disease activity is stabilized and symptoms improve, which might take several weeks. Then the dose is very carefully and slowly tapered down over a long period, often 6 months to even 2 years, sometimes longer, to find the lowest dose that keeps the inflammation suppressed. Stopping too soon can lead to relapse.
A very long treatment course.
It is. And because long-term steroid use has significant side effects, management also includes strategies to mitigate those. Aspirin is also often recommended alongside the steroids to help reduce the risk of stroke, which is another potential complication. And crucially, patients on long-term steroids should also receive medications for GI protection, like a proton pump inhibitor, PPI, to prevent stomach ulcers, and bone protection, like calcium, vitamin D, and often a bisphosphonate medication to prevent steroid-induced osteoporosis.
Right. Protecting against the side effects of the cure.
Exactly. It's a balancing act. Interestingly, NSAIDs like ibuprofen, which help with many headaches, are not generally considered helpful for the underlying inflammation of GCA itself.
Good to know. Now, this raises the most critical question about GCA. You mentioned complications. What is the most serious potential complication of giant cell arteritis if it's not diagnosed and treated promptly?
This is absolutely the most critical point about GCA. The most serious potential complication is blindness.
Blindness, wow.
Yes, permanent vision loss. The inflammation can affect the arteries supplying blood to the optic nerve and the eye itself. If that blood supply is cut off, it can lead to irreversible damage and blindness, sometimes happening very suddenly. Approximately 50% of individuals with untreated GCA might experience some form of visual impairment, ranging from transient blurring or double vision to sudden, complete loss of vision in one or both eyes.
It's terrifying.
It is, and that's why prompt diagnosis and immediate initiation of high-dose steroid treatment are so incredibly crucial. The treatment is primarily aimed not just at relieving the headache and other symptoms, but fundamentally at preventing this devastating and often irreversible complication of vision loss. It's a true medical emergency.
Wow, what a truly deep dive into the whole world of headaches. I mean, we've covered so much ground, from telling apart the most common types like tension and migraine to spotting those critical SNOP red flags for secondary causes, and all the way through lifestyle adjustments and the different medical therapies. I feel like I've gained a much clearer mental map for understanding head pain now.
Yeah, and if you think about the bigger picture, really understanding these distinctions isn't just for doctors or nurses. It's incredibly valuable for anyone who experiences head pain themselves, or maybe is supporting a friend or family member who does. Knowledge really is empowering when it helps you understand what might be going on with your own body, or helps you ask the right questions, you know?
Absolutely. So what does this all mean for you listening right now? Hopefully you feel equipped with a much stronger framework to approach headaches. You can better distinguish the common, usually benign types from the potentially concerning ones that need urgent attention. And you have a better grasp of the wide range of effective strategies available, from lifestyle changes to specific medications.
And maybe here's a final thought to sort of mull over as we wrap up. We know from the data that the vast majority of people who experience primary headaches, like migraine or tension type, actually self-manage. They don't necessarily seek formal medical care for every episode.
Right, most people just deal with it.
Exactly.
Yeah.
So this raises an interesting question. How might a deeper, more accessible understanding of these conditions, the kind of distinctions, triggers, and treatment options we've just explored, how might that empower even more people to manage their symptoms more effectively on their own? Or, perhaps just as importantly, help them recognize with more confidence exactly when it is time to stop self-managing and seek expert help, potentially catching something serious like GCA much earlier. Food for thought.